Good afternoon. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to today's conversation. Before we begin, I'd like to thank our co-hosts, Our Bodies Ourselves, and Meredith Brown and Alicia Noel, whose work make today possible. Thank you. Before we begin, I'd also like briefly to acknowledge for a moment recent events in our country. The conviction of Derek Chauvin for the murder of George Floyd is a step towards a justice long denied in this country. It's an imperfect step, incomplete in the face of persistent systemic challenges to the lives and health of communities of color in general and Black communities in particular. But it is justice nonetheless, cause perhaps for an exhale of the breath we have collectively held this past year. It is a step towards addressing the legacy of racism, which has done so much to keep our country sick. And it is a step that reminds us of how much more there is to be done. I shared fuller thoughts on yesterday's verdict in writing. It is on our school's homepage if anybody is interested. With cautious hope for the future, we move on to today's conversation. This conversation is part of a series of public health conversations meant as spaces where we can convene to discuss what matters most for health. We join as a community to hear from distinguished guests who guide us towards a deeper understanding of the forces that shape health. These forces include politics, the economy, the environment, and societal changes in how we relate to each other as individuals and collectively. Often, such change is sparked by social movements or galvanizing political leaders. In 1971, it was sparked by a book. Our Bodies Ourselves was a revolutionary publication. Since its release, it has supported a vision of women's health guided by data and personal autonomy. It helped women become better informed health consumers, normalized discussing key women's health issues in the public debate, and pointed women towards greater engagement with the political determinants of health. Much of our current conversation about women's health is a continuation of the conversation started by the publication of Our Bodies Ourselves. In celebration of the 50th anniversary of its first publication, we are truly honored today to host a panel of experts to discuss a range of topics core to women's health. And I now have the great privilege of introducing today's moderator and the intellectual architect of today's events, Judy Norsigian. Judy is the founder of Our Bodies Ourselves. I have learned from talking to Judy over the past couple of years, and I'm very much looking forward to hearing from her today and learning from her and all our speakers. Judy, over to you.
Thank you so much, Dean Galea. Our Bodies Ourselves has deeply appreciated the many years of support from the BU School of Public Health faculty, as well as the institutional support received a couple decades ago when the school provided us with free office space during a challenging transition period. We will always be grateful for the fruitful collaborations that have enriched our work over many decades. My task today is to provide a brief overview of the women's health movement in the United States as backdrop to the three presentations that will be underscoring how some of the early women's health movement work has continued up to the present, sometimes morphing to adopt a more intersectional approach that addresses key current crises such as climate change, institutional racism, growing wealth gaps, and the starkly contrasting political narratives that continue to divide this country. A robust women's health movement began in the late 60s and early 70s, largely around efforts to legalize abortion. Many activists subsequently took up other health issues, organized women-controlled health centers, created women's health publications such as Our Bodies Ourselves, and established advocacy projects seeking to change public policies affecting women's health. Nationally, activists in the women's health movement found a unified voice with the establishment in 1976 of the Washington, D.C.-based National Women's Health Network. Our Bodies Ourselves and the network have worked together on many initiatives and were successful in creating greater visibility for feminist and consumer critiques of health and medical care within the media and with policymakers. Although many of the women's health movement organizations of that era were primarily white and middle class in their composition and orientation, they sometimes addressed the concerns of poorer women and women of color. For example, many of us fought hard to stop the sterilization abuse prevalent in so many parts of the country. I'd like to give a quick shout out now to Dr. Alice Rothschild and Our Bodies Ourselves colleague who was a Boston University medical student back in the 1970s. She played a major role in drafting the HEW sterilization abuse guidelines intended to curb this problem. Starting in the 1980s, women of color created both local and national organizations to focus more intensively on their priority issues. Women with disabilities, older women, and lesbians also organized to form new groups and insisted that more well-established organizations better address their particular concerns. At Our Bodies, Ourselves, we initially focused on better understanding our bodies, on the demystification of health and medical care, and on redefining and reclaiming female sexuality rather than relinquish control to the male experts who typically had absolutely no training in human sexuality, let alone female sexuality. At the time, 98% of OBGYNs and 92% of all physicians were men. And the condescension, sexism, paternalism, institutional racism, and homophobia were all substantial problems that we sought to address in various editions of our book. The first edition of OBOS, a 112-page newsprint booklet published by the New England Free Press in December of 1970, was used by thousands of women in consciousness-raising groups and informal bodies courses organized in community settings across the country. Here is a little show and tell. Women and Their Bodies, the title of the first printing in December of 70, followed in March of 71 by the newsprint edition titled for the first time, Our Bodies, Ourselves. These are, of course, collector items right now. The phenomenal success of this underground publication, over 250,000 copies were sold mainly by word of mouth, demonstrated women's profound need for this kind of clear, comprehensive information about our bodies, as well as a better understanding of how medicine had become a means of social control over women. You can read more about this early history of the book at our website. Critiques of medicine as an institution of social control over women emerged during these early decades, alongside analyses exposing problems such as racism, classism, sexism, ageism, ableism, and homophobia. Women also protested the emphasis on pathology and treatment rather than prevention. Some argued that this led to the over-medicalization of women's lives, which turned normal events such as childbearing and menopause into necessarily disabling conditions requiring routine medical intervention. The women's health movement has long recognized systemic factors central to securing women's health and well-being. Things like safer, cleaner, less stressful living and working environments, adequate food and housing for everyone, reduced violence against women, and of course, a national health program that would guarantee everyone access to quality care. At the same time, we understood that poverty was the single most important factor affecting our health, not access to medical care per se. In the resources that will be sent out later with a link to the recording of this webinar, we will include more about some of the early accomplishments of the women's health movement. And now I will just mention a few examples. Patient package inserts, or PPIs. This FDA program was initiated in response to women's health activism calling for better information about birth control and estrogen products used during the menopause. We wanted these to be included in packaging. As you know, this program at the FDA was later expanded to include many other drugs. Federal sterilization abuse guidelines promulgated by the Department of Health, Education, and Welfare. Campaigns to stop sterilization abuse were successful largely because of the multiple efforts of activists, journalists, and community organizations. Ironically now, with the exception of a handful of states in the US, poor women who rely upon Medicaid can obtain a federally funded sterilization, but not a federally funded abortion. As most of this audience is well aware, we have yet to eliminate the infamous Hyde Amendment, which continues to restrict access to abortion services needed by so many women who use Medicaid-funded services. Breast biopsy. In the United States, for many years, the standard practice upon doing a breast biopsy and finding malignant tissue was to proceed immediately with a mastectomy. Women would basically go to sleep and wake up without a breast. Several years of hard work, especially on the part of activist and journalist Rose Kushner, resulted in a landmark National Cancer Institute recommendation that breast biopsies be done as part of a two-step procedure in most cases. That is, they advised that a diagnostic biopsy specimen be studied with permanent histologic sections before various treatment options would be then discussed and chosen by a patient in consultation with her caregivers. During the 1990s, the women's health movement also had a role with other important developments. For example, the package of bills introduced in Congress and known as the Women's Health Equity Act, and the ambitious NIH Women's Health Initiative launched in '93 to support research on heart disease, osteoporosis, and breast cancer. Some activists successfully pushed for more research into environmental factors affecting breast cancer risk, and several creative legislators found funds for this research even in our nation's defense budget. Over time, consumer health activists also became more systematically involved in NIH meetings that actually set the research agendas. A good example of this is how groups influence contraceptive research priorities to include attention to female-controlled barrier methods of contraception. This was especially important given the rise in STIs, sexually transmissible infections, especially AIDS and HIV infection. Our Bodies, Our Cells was involved in organizing several global dialogues to help foster greater mutual understanding among women's health advocates, scientists, and funders. And these meetings did have some limited impact on contraceptive research and development. One of our speakers today, Charlie Ruth Castro, will be speaking to the growing interest in using caps to collect menstrual fluid, largely because of environmental concerns. And who knows, this interest may become a path to greater use of diaphragms and caps for contraception as young women become more comfortable with using menstrual caps. Childbirth represented an ongoing concern as excessive medicalization and lack of adequate technology assessment continued to be problems. I won't say more about this topic as Nashira Baril will be addressing key birth justice concerns, especially as related to women of color in this country. For groups like Our Bodies, Our Cells, and for me personally, there is strong interest in expanding access to midwifery care in all settings. Despite ample research about the enormous value of midwifery care, we continue to encounter both political and practical problems in advancing such access. Perverse financial incentives often play a substantial role here. Special gratitude I want to mention to people at the BU School of Public Health who have worked with us on this effort. For example, Jean DeClercq and Joanna Rory. Wendy Chavkin will address some of the concerns around assisted reproductive technologies, gestational surrogacy, new genetic technologies such as CRISPR and gene transfer, and the use of young women as egg providers. These continue to be major concerns for at least some organizations, such as Our Bodies, Our Cells, and our close colleague, the Center for Genetics and Society. We are particularly concerned about heritable genetic modifications and have joined with those scientists calling for a more cautious approach here. In closing, I just want to mention that maybe our crowning achievement at Our Bodies, Our Cells over these many decades is the collaboration with women's groups across the globe who've seen the book and decided to adapt it for their own cultural and linguistic realities. They actually produced a book that was needed in different regions of the world, people using different languages. I have with me right now an example of the most recent publication, Notre Corps Nous-mêmes, produced by a younger collective in France. They were advised by a couple of the older women who produced the original Notre Corps Nous-mêmes back in the 1970s. But this is an incredible example of how a younger generation has taken the ideas of the women's health movement, but reshaped and remolded them to meet the needs of today. If you go to our website, you can see covers for the dozens of foreign language translation and adaptations of Our Bodies, Our Cells. Work right now is going on in Brazil, where our colleagues are in the last third of the book, producing a translation adaptation that will be available by the end of the year. These are so important in our work going forward, our collaborations with women in other countries. And I know that our speakers today have actually done a lot in these spaces. Our first speaker is going to be Nashira Baril, one of my favorite people in Boston. And Nashira is what I call an amazing public health activist. She actually went to BU School of Public Health, and she is now our lead force in creating the Neighborhood Birth Center here in Boston, Massachusetts. Nashira, I will encourage people to read your longer bio online, and please use your time to carry us through your experience.
Thank you so much, Judy. What an honor to be here. Let me just adjust this. How's that for sharing? All right. All right. Oh, it really is an honor to be here. I wanted to start with this picture. This was my first experience with home birth, a windy day in late April. It'll actually be 34 years ago next week. And as I was reflecting on this experience as it connects me to my current work, I was realizing that my childhood was straight out of the pages of Our Bodies, Ourselves. Years before this photo was taken, I was the 3-year-old running around a circle of hippies in a women's self-help collective as they were learning to fit cervical caps. I was squacking the speculum like ducks and suctioning clean cervical caps to my face as a very young child. So I definitely feel a real honor to be here. Maybe you could predict that I would end up here today with a degree in maternal and child health from BU, having had home births myself and working to open the first community birth center here in Boston. But what an honor to be speaking at the 50th anniversary of Our Bodies, Ourselves. I want to start and just invite folks, there's many folks on the line today from calling in from all over the world, to just take a moment to, close your eyes if you want, study this photo if you want, and imagine with me, kind of feel anchored in your body and imagine or remember, for those of us who had access to it, what it feels like when love is at the center of healthcare, right? Imagine that when people get pregnant, that institutions, policies, and culture affirm their choices about pregnancy. That if they choose to give birth, that institutions and culture affirm that there's no wrong way, wrong body, or wrong gender to give birth from. I think it's so important to tap into this, to really think about what it feels in the body, to bear witness to this, and to understand what's possible when people engage in healthcare where their full selves and their full identities are honored. I often think about what's possible for us as a collective, as a society, when we're able to achieve this. And so I just want to enter into this from a place of really submitting to how much birth matters. Research has shown that the conditions of our birth and the first year of life can shape our health, everything from risk of asthma for a baby to postpartum depression for the birthing parent. And I think how babies come into this world matters for our collective public health, for our economy, and I'd go so far as to say for our climate. And with this breath in our bodies, I want to just take a minute to summarize the problem of maternity care. And I'm not going to go through it in detail. I'm going to make an assumption that many folks here know this or know where to find out more. And I'm going to spare myself and other folks of color on the line the traumatic experience of rehashing all of the data that shows persistent racial inequity across all measures. And in maternal and infant outcomes as well. There are racial inequities across every system in this country, from education to housing to food insecurity to health outcomes, where white folks fare better than Black folks and other people of color. It's true in Boston, it's true across the country. And these inequities exist because this country was designed to advantage white people. We have a history of colonization and genocide and an entire economy based on a racial hierarchy, a man-made racial hierarchy. And our investments, and I'll speak to the area of public health because that's my area, but I think it could be argued across all systems that our investments have largely been in programs. We try to address structural inequity by creating healthy eating initiatives, walking paths, as if it's the behavioral choices or actions of people that primarily shapes their health and not larger interlocking systems. And so there's a crisis of maternal health in this country, a crisis that represents our history, centuries of othering, and it really also illustrates our divestment in maternal health. And I'll talk more about that in a moment. But that is to say that it's like public health and maternal health, it's like the canary in the coal mine, right? It's the indication of the health of a population. And Black women are leading the response to the maternal health crisis in this country, even though we didn't create it and we suffer the worst outcomes. Professor John Powell of UC Berkeley, I was attending the Othering and Belonging conference earlier today. He coined the term targeted universalism. It's the idea that we target or center the intervention, the reimagining, the planning for the future with those and led by those who are most marginalized. And in doing so, everyone wins. There's a universal impact when we can design the intervention at the inequity. And so there's much data, qualitative and quantitative, that shows persistent inequity in outcomes by race and ethnicity. But what I want to layer is this truth about how the US is doing compared to other economically advantaged countries. Often in public health, when we talk about health inequity, we say we need to close the gap. But I think that there are consequences to that. It suggests that the white rate is the goal, right? And maternal deaths in the US are more than twice that of other high-income countries. And when ranked among the 37 other economically advantaged, economically developed countries, the US is at the bottom 3 for infant mortality. We're this red bar over here at the far right of the screen. If the white population of the US were its own country, we would claim just 1 rank higher. That's the green bar over here. I think it's really important to name that the healthcare system in this country is not working well for anyone. And I think we have to get clear on that. And I think it's a call into white folks to really be clear about working in solidarity to improve a system for everyone, and to really interrupt this idea that we're working on behalf of, poor Black and brown women for whom the system's not working. And I would say everyone needs to get free. We need to reimagine the system completely. This is the same data when we look at life expectancy. Again, the red bar is the entire US, and the green bar, just slightly above Chile, is the United States if it were a white-only country, and how we would rank among other economically advantaged countries. And this really resonates with what I heard when I started working on this birth center idea here in Boston, that it's not really working well for anyone. We launched a survey in 2016. Professor Jean DeClercq pushed me and said, well, if you build a birth center, will they come? So we launched a needs assessment, and in the first few months that the survey was out, probably not surprisingly, the respondents were overwhelmingly white. 70% had a graduate degree or higher, and almost 70% were earning $200,000 a year. So a very white, wealthy, educated, cisgendered pool at the start of the survey. We later worked to make sure it was a more representative sample. But there was something in that data. And what we heard was that those folks were largely dissatisfied with their pregnancy care and birth experience. They mentioned that the nurses made fun of their vocalizations, or they felt like they were giving birth inside of a machine. So, there's a real, there's been a lot of studies about patient satisfaction, birthing people feeling disempowered, not well cared for, and that's really real. And I think we need to hold that as we think about what reimagining looks like, and revisiting, I will say too, as we think about our history. And we know that if well-educated, wealthy, cisgendered white women in Boston are complaining and feeling dissatisfied with the maternal care system, then we understand when we understand structural disadvantage, that who else it's not working for. And so I would just say that the goal can't be to try to make the rates for Black and brown folks, birthing folks, that of white folks. We need to improve for everyone. And we know that midwifery is part of the solution. The World Health Organization reports that midwives are especially well equipped to provide respectful care that meets standards, that is race and gender and culturally inclusive, responsive to patient voices. Midwifery care is high value, improves birth outcomes, and yet the majority of US counties in the United States lack access to midwifery. And childbirth is the #1 reason for people being admitted to the hospital in the United States. And 85% of those pregnancies are considered low risk and could be seen by a midwife outside of the hospital. So we've got some dissonance to reconcile here between our espoused beliefs in equity and healthcare for everyone, knowing that in other economically developed countries, the investment and expansion of midwifery has helped to improve maternal and child health, and we have not made that investment in this country. In fact, it's been the opposite. Because of the history of how midwifery was made illegal in this country, there were 19th and 20th century policies that prioritized obstetrics and racially redlined midwifery education and licensure. And we swung to, at one point in this country's history, midwives caught all of the babies. And these days, 98, almost 99% of births take place in hospitals attended by physicians. OBGYNs are overrepresented in the US maternity care workforce. And there's an overall shortage of maternity care birth providers, both OBGYNs and midwives, relative to the number of births we have. The US has the highest maternal mortality rate among developed countries, and it's directly connected to the lack of investment and the active divestment that we've made. And I think we have to talk about the role of policy here, right? So like how the US is the only economically advantaged country to not guarantee access to provider home visits or paid parental leave in the postpartum period, despite the fact that a large number of maternal deaths occur after childbirth and in the infant's first year of life. How am I doing on time? Let me speed up a little bit. So I want to, stay on policy for just one moment and name this bill specifically. That right now advocates are pushing for this Out of Hospital Birth Access and Safety Act. That not having a process for licensing certified professional midwives like those who attended my home births means that their care is often not covered by insurance and creates barriers to safe out of hospital options for many. For context, here in Massachusetts, there's one community birth center in the state. It's out in Northampton, Seven Sisters, and it opened just 6-8 months ago in August of 2020. So if you're pregnant in Massachusetts and you're not out in Northampton, you most likely default to hospital birth. And if you have the economic means and familiarity, you can pay out of pocket for home birth, which for me costs about $4,000 each time. So we have an air about us in Massachusetts as a medical metropolis, despite the fact that we rank in the bottom third of states for maternity care integration. We're really missing an essential piece of the evidence-based solution to the maternal health crisis, which is expanded midwifery care. So there really is an increasing demand for out-of-hospital birth, and not just in COVID, but these are just some screenshots of emails and text messages that I get. One of these came in yesterday, and I get about 5 a week. The crisis of the last year in COVID has absolutely helped to amplify our cry, but Judy and Joanna Rory and others have been crying for a long time that it's high time that Boston have a community birth center. And these messages come in all the time, and some of it is in response to a fear of COVID, and some of it is just folks recognizing that their desire to feel agency in pregnancy and childbirth and to be treated well, and even to survive their childbirth experience is of the utmost importance. So as I wrap up, I want to just invite folks to think a little bit about birth centers, these safe home-like spaces outside of the hospital. These are pictures from some of my favorites in the country, where comprehensive midwifery care is provided. Birth centers lower preterm birth rates, prevent low birth weight births, reduce C-sections, save costs, and reduce racial inequity. So it's like we know where some of the answers lie. But here's the thing, in spite of the growing number of birth centers in the country, there are nearly 400 now, and that's grown really exponentially in the last 15 years. There's inequity in how birth centers get started. The majority of birth centers are for-profit institutions started by midwives who had an existing practice, and they're seeded by that midwife's personal savings or lines of credit. And there's that ugly truth of inequity again, that structural inequity and advantage. So when we understand who got to be a midwife because of policy, and we know that that was racially redlined, and we also know that access to education, real estate, and generational wealth continues to be racially redlined, we understand that if you're gonna be a midwife and have the resources to open a birth center, most birth centers are started by white folks. In addition to that, they're coming out of their own pockets to open birth centers. And so I dare say that's not a great model for sustainability or overhauling our healthcare system either, that they're going into debt to provide critical care and are stretched often beyond their capacity. Additionally, many birth centers choose not to accept Medicaid patients because the reimbursement rate is low. So again, the cycle of kind of policy creating inequity is here again. And so there are 399 birth centers in the country, and only 3% or 12 of those are led by people of color. And so I think we can and must do better. We are serious about improving outcomes and improving outcomes across population. So I just want to leave you with this. This is a vision of Boston's first birth center. The idea, as I mentioned, was born decades ago. And at that time, the idea met resistance from hospitals, insurers, and electeds. And those are stories that Judy can tell and others that predate me. But their vision of a liberated healthcare center never died. And it's a space that really reverberates our bodies ourselves, right? It's here. And in our hearts. And so in our vision of Neighborhood Birth Center, we center the physical, emotional, and spiritual healing and care for people at the margins who are most often left out of the design of healthcare. Right now, Black, brown, queer, disabled folks are designing this first birth center. And as such, it's a place where pregnancy and birth are tended to as the most beautiful, cared for moments of our lives. And I think from COVID-19 to who gets to open a birth center to who gets access to midwifery, we have to reconcile with the fact that inequity is not natural. The differences have been legislated, and the solutions can also be legislated, funded, and curated by community. So I'll just end here with another birth story and a shout out to my mom, who I think is on the line. In this picture, my 4-year-old is holding me through transition, and her brother was born about 3 minutes after this photo was taken. And just as my mother's birth shaped my worldview when I was a child, the birth of my son transformed my daughter's worldview. She builds Lego birth centers, and all of her Barbies are pregnant or midwifing. And I just want to recognize that birth touches more than those that are in labor. My neighbors and colleagues can now point to my story and say, I know someone who gave birth safely outside of the hospital, and they have that as part of their narrative. So I just want to invite folks to be part of a shifting narrative that helps prepare and tend the soil for the opening of our first birth center. There's an important role of remembering, unearthing, and reclaiming the stories, both where healing and trauma have happened, and celebrating what is hard and what is glorious about maternal care and birth. And I'll leave you with just birth matters for future generations.
Wow, that was extraordinary, Nashira. I am so moved and so grateful for all your work. I want to answer some of the people who've been asking questions, that there's all kinds of ways you can help out, both with the Neighborhood Birth Center and go to the website. By the way, we will have resources, websites, all included when we send out the Zoom link for this session, where it's available at the BU School of Public Health website as well. But I want to underscore that the birth center does need support from the community, and there are all kinds of ways you can help out. You can email me, find me at the Our Bodies Ourselves website, and I can give you some ideas. And also, as Nashira mentioned, we simply must see the midwifery bill, the Out of Hospital Birth Access and Safety Act, pass this legislative session. There is overwhelming support. We know it would pass if it could come up for a vote. And this will be key to getting birth centers well-staffed in the future, and also to having women who choose to have home births have the safest home birth possible. I am not going to say much about that, but the Bay State Birth Coalition has great resources, and the website is another thing we will refer you to. Our second speaker is not here. We're not sure what the problem has been with getting access from Colombia, Charlie Ruth Castro. So we're going to move directly on to you, Wendy, if that's okay. Wendy Chavkin is an OBGYN, a public health activist based in New York City, still teaching at Columbia University, and one of my longtime favorite colleagues and friends. We worked on so many different issues over the years, and Wendy has contributed as well as a reader to various editions of Our Bodies Ourselves. Most recently, we worked on a not very good piece of legislation that Governor Cuomo in New York State decided to include in his annual budget so that it wouldn't have to come up for any public discussion. And she might allude to that a little bit in her remarks. But Wendy, I'm going to pass it over to you and your slides. And thank you so much for joining us.
A great pleasure. And if I have a moment of bumpiness when I try to do the slides, you'll all be very kind to me, right? So I first encountered Our Bodies Ourselves when I got to college, and it was that first newsprint edition that Judy talked about. It also came on the heels of something else that I was very interested in, and that speaks to Nashira, and that was the move towards natural childbirth. Thank you, Dr. Lamaze, and efforts that followed. Both Our Bodies, Ourselves and the earlier natural childbirth movement of that time saw the knowledge of biology as power that enabled people to participate in decisions about their own care. But there have been several developments in these past 50 years that depart from that vision. One is anti-science, manifest in such ways as questioning vaccinations, climate change, or the utility of protective measures during a pandemic. The other, which I'm going to spend more time on, is an uncritical eagerness with which some new medical technologies have been embraced and deployed widely ahead of evidence about their safety or their efficacy. Some are employed in ways that reveal and aggravate the commodification of human beings and biological processes. Assisted reproductive technologies, for example, or ARTs, implicitly disregard a holistic and integrated understanding of human biology and instead disaggregate the biological processes related to pregnancy into component bits and component isolated processes separable from the pregnant person, and then frame these as commercial entities available for purchase. There is much to unravel about what this commodification means for human dignity, for unequal and exploitative relationships, and for gender inequality in new guises. I'm going to highlight here the risks to health that result from uncritically embracing this approach. And I'm going to try to make it concrete by telling you about a recent debate over legalizing commercial surrogacy in New York State. New York had prohibited commercial surrogacy for decades following an ugly public contentious case in the 1980s known as the Baby M case. Since that time, however, commercial surrogacy has popped up in many other locales. And to minimize the possibility that the surrogate claim parental rights to that future child, which is what had happened in the Baby M dispute, most such contracts now mandate that her ova not be used. This relies on the assumption that parenthood is based solely on genetic contribution, a male model, and that pregnancy is irrelevant. It also means that IVF is required. The whole endeavor is so expensive that contracting parents are generally quite privileged, although now these folks include both same-sex and heterosexual couples. The people serving as surrogates and third-party egg providers are exposed to health risks on behalf of the contracting future parents who pay them. The problem is that there are problems. Each step entails potentially significant health risks for the woman who provides the eggs, for the woman who acts as surrogate, and for the resulting children. These risks result in part from requiring IVF, and they result in part from medical practice decisions that give higher priority to the interests of the contracting parents than to the health of those acting as surrogates, or those providing eggs, or even to those born as the end result. I shall flag a few of these.
Wendy, sorry to jump in. Were you mean to show slides? Because we don't.
I am right now going to do it.
Oh, okay, good. Thank you.
Here we go. 1 second. Oh, sorry. Start from the beginning. Okay.
Perfect. We see those. Thank you.
Implanting those serving as surrogates with embryos created from other women's eggs increases their risk of preeclampsia, which is not only dangerous during that pregnancy and postpartum period, but is associated with increased risk of cardiovascular disease for the rest of their lives. The best medical practice is to transfer one embryo into a uterus, as is normative in Europe. Hang on a second. Here, however, the transfer of more than one embryo is more likely when the woman is acting as a surrogate, perhaps because the commissioning parents consider it financially advantageous to get two for one, only pay for the experience once. In the 15-year period ending in 2013, more than 2/3 of the infants born of surrogacy were from twin pregnancies. Twins, in addition, are generally delivered by C-section, which adds the risks of surgery and increases the risk of significant complications in subsequent pregnancies. Let's look at the risk for the babies. Children who are twins or whose mothers were preeclamptic are more likely to be born too soon or too small, to have increased hospitalizations and a host of other problems. Their long-term health and that of their descendants may also be permanently affected in unknown and unpredictable ways if the embryos were tinkered with in an effort to select for desired characteristics, or if they were created via germline modification, which the New York State bill permitted. More than half of surrogacy arrangements involve the use of purchased eggs. The process involves injecting the egg donor, as she's known, although she is really the egg seller, with high doses of hormones that cause the ovaries, which normally produce one egg a month, to produce dozens. And the higher the hormonal dose, oops, that went too fast, sorry. The higher the hormonal dose, whoops, let me come back to where I was. The higher the hormonal dose, the more eggs she's going to produce in a given cycle. This can lead to ovarian hyperstimulation syndrome, a serious and at times fatal complication. Because there is no system in place to track egg donors, there's no way to monitor how many times a woman has produced eggs for money, and women have reported doing this more than 15 times and producing more than 60 eggs in a cycle. The lack of follow-up means that we have no idea if multiple rounds of ovarian stimulation will affect women's later health. Some of these concerns apply to those who freeze their eggs for their own use as well. Nor do we know the long-term consequences for the health of those serving as surrogates of undergoing the hormonal treatments necessary for IVF. Since IVF results in a birth less than half the time, many of these women will undergo multiple rounds of these treatments. I keep repeating, we don't know, we don't have data, but meanwhile, these practices have been uncritically embraced and widespread. Some of you are going to encounter this through ads urging you to sell your eggs or to freeze them for your own use. Yet there is a precautionary principle in public health and medicine, which asserts that it's better to prevent problems by not engaging in activities until it's reasonably certain that they will not produce harm. Several groups organized to oppose the bill in New York State. Let me stop this sharing. I was involved with a group of medical and public health folks who emphasized the concerns about health. We were joined by our bodies ourselves, who contributed their technical and their political organizing savvy to our efforts. We stopped the bill in 2019 largely because we persuaded women legislators to be concerned about the health consequences. The bill was reintroduced a year later, and we looked likely to have a second win. But then the pandemic hit. And while the legislature was focused on urgent pandemic-related needs, the governor, who had major funders who supported the bill, used a maneuver to sidestep debate and cram it through. Similar bills are being considered in other states. Those who seek commercial surrogacy do so out of the desire to love and raise a child. While we are all supportive of this, we also have a responsibility to do no harm. In the 50 years since Our Bodies Ourselves was born, women's participation in paid employment dramatically increased. However, most societies still assume that women are responsible for domestic life, for the care of children, and for older people. Nor has the structure of work changed much in response to this change in the working population. And social supports for family care are still slim. Around the globe, women have responded by delaying childbearing. The reproductive biological time frame, however, is not in sync with these recent social changes, and people encounter the ceiling of their reproductive lifespans when they are eager to begin parenthood. More recently, ideas about gender, parenthood, and family have expanded. ARTs appear to offer technological solutions to all of these social changes and social problems. Let's craft social responses to social problems and try to figure out how we can support new innovative ways of forming families and caring for children while simultaneously respecting biology and science and without inadvertently creating harm to health or rights. Thanks. You're muted, Judy.
Sorry about that. I pressed unmute, but it didn't work. I just wanted to mention that we will hopefully get Charlie Ruth Castro in before the end, but if not, I will say a few words about her presentation afterwards. I think I'd like to go directly to some of the questions and some of the issues that have been raised. One of the things that concerns many people, Wendy, is that as we speak about these issues, and they are important issues, we sometimes appear dismissive of the issues faced by women who cannot have children naturally with their own bodies. And this is what one of the participants is saying, though we may long to. And the experience of same-sex couples. All of the options available, IVF, egg freezing, surrogacy, adoption, are very expensive and thus inaccessible to most women or gay male couples. I cannot afford any of these, but suffered from premature menopause. How do you respond to our experiences and options?
I think these are very, very real concerns, and that is what I was obliquely referring to when I talked about at the end, let's see if we can figure out innovative ways to help people have children and have families. But I do want to say that I don't think the answer is to take advantage of somebody else and to expect somebody else to undergo health risks on your behalf. So maybe we can craft something new. Maybe we can figure out something that will, be good for all of us. And I don't mean to dismiss those very real concerns. But I am not at peace with the thought that somebody else undergoes risks for you or for me.
I think that's a good point. And I think it's also sometimes difficult to have all of these issues front and center. I remember meeting a woman who is a physician now practicing in Sacramento. And as a medical student, she chose to basically provide eggs. And she thought of it as a way to make some money, badly needed money for her medical school expenses. And she ended up having pretty serious problems. She had one at the time of egg extraction, but she also later on had infertility problems. And when she went to the fertility clinic, they said, "Don't worry, we see lots of young women like you." Well, she was in her mid-30s by then, who have had these problems and we can help you. And she contacted us because she was concerned that so many young women have no idea that there is an awareness that problems may result, but we're not doing long-term safety data collection. And that's the reason why this group called We Are Egg Donors formed. It was formed by women who are egg donors, because they're not saying we shouldn't do it, but they're saying we really need to do due diligence, collect this safety data so that young women can have informed consent, which they cannot have now. And I think this is a great example of the precautionary principle in public health, where we have to understand that lack of data regarding safety and efficacy is not the same as proof of safety and efficacy. When we don't have data, sometimes we assume, oh, it's all hunky-dory because people are doing it, but that's not the case. Nashira, I would love you to say a few things about the current state of the birth center and the ways in which you'd like to invite support. People are asking.
Great. Oh, can you see me, hear me?
Mm-hmm.
Great. Yeah, we welcome your support. Because of the inequities I mentioned and how hard it is to start a birth center, we've been at it in a very volunteer capacity for the last 6 years. And we raised some funds last year that allowed me to come on half-time beginning in January. And we're going to be bringing on another half-time person soon. So we're building our capacity to be able to do all the things from real estate. I didn't get to mention that we are really committed to co-locating in a shared space with other healers and movement activists to make sure the birth center is anchored in a really community space. I imagine also because I know someone mentioned in the chat that there's a birth center in Beverly. Cambridge and Beverly are both hospital-owned birth centers, and we're looking at a community-based nonprofit model. And to really make sure that it feels like it's centered in the community, that it is in a shared space where people may have access to coming into the space for an event or co-working or a men's healing circle or something else, and peer through the window and be able to see what's possible, and in that way kind of expand their understanding of out-of-hospital birth and spread the word in that way. So those are all the things on the horizon. We need to raise $3 million, so there's no way around saying that is a need we have. Donations, but also connecting us to a bigger capital to understand like how's capital moving in Boston in a way that can accelerate this project. Another big priority is finding a hospital partner. We are rich with hospitals and community health centers, and we are working hard to try to build a case so that each of those hospitals are maybe jockeying for our partnership. But right now the state regulations require that we have a hospital partner. And unfortunately, there's some disincentive, like hospitals, we're hoping that a hospital is interested in improving outcomes and partnering with us on that. And so there's a process of trying to navigate that. And COVID has changed a lot of the plans that we had for the narrative and community building work. But we're launching some things on social media and invite you to follow us on Facebook and Instagram. But I think this one really important piece is the narrative work that I often say that if we had the $3 million and the building and we were cutting the ribbon tomorrow, that we'd have a long way to travel for folks to feel, to one, like understand, what the birth center is it safe? Even if the birthing person, the pregnant person was interested in coming, it might be that, their family or their grandmother is trepidatious because of their own trauma or the stories of trauma that we carry. And so I think that there's a real important movement that we need to be a part of in the next couple of years of reclaiming the narrative around midwifery. Talking about one person in our needs assessment said midwifery is birth centers are for crunchy white women. And I nodded because of, my own history and how I came to understand it. But also there's a history that we need to reclaim, that the history of midwifery in this country is Black. And I think when we can share those stories and be a part of that narrative, it will really prime the community to be ready for that ribbon cutting so that folks are ready to sign up for care.
Thank you so much. And we must not forget the incredible tradition of Black midwives in this country, not just in the Deep South, but there as well. And if you listen to some of the presentations by those active with Under the Black Light, which is a great series of events sponsored by the African American Policy Forum, you can hear how Black midwives have played such a critical role. And people are out there trying to create these alternatives and these options. One of the participants mentioned the Beverly Birth Center, and I realize that is a freestanding birth center, but it's on hospital grounds and it's run by the hospital. And they have done a few things that actually have lost them accreditation. For example, they're using internal field heart monitoring, which is not something that is considered acceptable in a true freestanding birth center, according to the American Association of Birth Centers. Nashira is talking about a community-based birth center that is going to ascribe to the policies and guidelines that AABC has put forth already. And it also will allow for a certain amount of community independence. We have seen in this long history of women's health advocacy that when we introduce a good idea and we let a large institution take control of it, there's often a fair amount of co-optation that eviscerates some of the core of what we were trying to do and what we were about. So it's really important that Nashira's model, community-based birth center, go forward, and that we insist upon hospitals in the Boston area stepping up to the plate and providing backup like dozens and dozens of hospitals across the country do. And we're hoping that we will be able to, in fact, have some of the OBGYNs in Boston come forward with more, shall we say, impassioned pleas for such cooperation. Wendy, do you have anything to add to this issue of freestanding birth centers? You know something about the ones in Manhattan and in the Bronx.
The ones in Manhattan actually have been stymied by traffic. And that's just an urban concern. So that if one needed to get to a hospital and to an operating room quickly, you can't. You can't with all the most wonderful collaborative arrangements, you're stuck. And so I think there has to be an effort to actually, the co-location also has to take that into account. I don't know what traffic's like in Boston. I've been stuck in sort of rush hour traffic, but I don't know about round the clock. Whereas in Manhattan, or in New York City, it's awful all the time, except during a pandemic.
Yes, I'm reminded of the Cambridge Birth Center where when they needed to transfer someone, it was simply across the driveway to Cambridge Hospital. That was made easy by the proximity. The other thing I want to ask you to speak to, Nashira, is this issue of recognizing in an era of COVID, the importance of out-of-hospital birthing options for women and families that want to reduce their risks.
Yeah, thank you for that, Judy. There's certainly in COVID, last March, the first days that my children were both sent home and we were figuring all of that out, my phone was blowing up with folks who were pregnant, know somebody who was pregnant, and were panicking in those early days and weeks of adjusting to pandemic. I think that has certainly shed light on the need for an out-of-hospital option. I think that there's still a lot of kind of politicizing, bringing people along to feel really comfortable with the safety and the history, again, of midwifery. One of the home birth midwives that I know who was here and caught my son said that, similarly last March, her phone was ringing and she, was kind of full with families. And many folks were arriving out of fear, and there's a lot of work to do to assuage, to bring along not just kind of recovering from the fear of having an out-of-hospital option, but also to bring along a real sense of agency and trust in your body and the physiologic process and in midwifery. And so I think that kind of while COVID has forced the conversation, there's the conversations with midwives and getting folks to understand the scope of midwifery is really important too. I don't know if that answered your question. You're on mute.
Muted again, Judy.
I just want to also mention that one of our board members who had practiced in Syracuse, New York, had a lot of experience with backup arrangements and found that they worked very well, that they believe that if we have an integrated maternity care system where we don't have people delaying transfer to the hospital because they're not sure of how they'll be treated, they're not sure that the protocols are in place, that more timely transfers are arranged. And this would be true for both a birth center and a home birth.
Right.
You have a question, Nashira, from somebody wanting you to comment on how women using these centers would be monitored for health problems during pregnancy. For example, diabetes, preeclampsia, previa, complications of delivery, so forth, and afterwards, postpartum preeclampsia. Can you say more about how these centers would reduce maternal morbidity and mortality? And apologies for that thunder, I'm going to put myself on.
Sure. So I'm not clinically trained, and there are midwives on the line, but I will say that the midwifery model of care is, attentive to all of those things. And so folks would be screened, to see if upon pregnancy or even before pregnancy that they could be seen at a birth center for out-of-hospital care. And that, again, our hope is to have a really thorough arrangement and agreement with hospitals where providers can do, where medical providers, docs can do a chart review and can consult with midwives on high-risk cases and determine if transfer or if birth at the birth center is safe. And so I think, and I would also just add from my own experience of having home birth, midwives, when you don't have access immediately to surgical support, midwives are very attentive and have to call it early, right? So they're most of the transfers that happen from home or from birth centers are non-emergent transfers. They happen because of maternal exhaustion, where you've just been at it for hours and are ready for some support. And I think the second half of that question was about reducing maternal morbidity and mortality. I think, again, the model of care is listening to the whole person. And when I think about the horrific cases of maternal mortality, and in particular, Black women who have not been listened to in the hospital, saying that they're, having pain or bleeding or need, additional care, that the model of midwifery is really centering that person and listening and providing full support, emotional support. We also want the birth center to have access to and have relationships and contracts with mental health providers and other body healers and chiropractors, and really kind of be able to address all manner of body and mind. I see a couple things in the chat. I wanted to say one other thing too that just speaks to the need to seed and grow birth centers, right? That there's demand, they're growing, over the last 15 years, but still not accessible in communities of color and in many places across the country. Last year, I co-founded Birth Center Equity. I'll drop that in the chat as well. That's a national strategy to move full spectrum capital, so grants, loans, land, and equity to birth centers led by Black, Indigenous, and people of color. And that just speaks right to the fact that the resources needed to open birth centers have been racially redlined, and that midwives and midwives of color are really working to address the maternal health crisis in this country. And again, when the strategies and the interventions are led by the folks who are most proximate to the problem, closest to the problem, that's when we're going to get equity. And in that way, we're going to create birth centers that work better for everyone. So I often think kind of like, what are the policies, and not just think about it, I'm leading this with the folks who have the answers. What are the policies and programs and strategies that we need to be building into the design of this birth center to ensure that it works well for an undocumented brown trans person, who's disabled, when we can think about all of the ways that structural disadvantage plays out in their lives, and that a birth center can begin to mitigate and meet some of those. In that way, we'll create a birth center that works better for everyone, right? But only in that way, because if we're not explicit about the inequity, then we will design in the same ways that many institutions replicate white supremacy culture and then try to retrofit with a diversity or inclusion lens.
This is a good point to mention, Nashira, that freestanding birth centers are designed for primarily low-risk childbearing women. Doesn't mean you can't have a complication in a low-risk pregnancy, but the fact that there is screening means that you don't have some of the predictable things that could go wrong with a birth. The other thing is that we've had studies of freestanding birth centers. Decades ago, the New England Journal of Medicine even published a major study. No question that these birth centers have equivalent, if not better, outcomes than the hospital setting for comparable groups of women. Subsequent studies only reinforce this. Dr. Michael Klein, who's based in Vancouver, who started a major listserv for more than 1,200 practitioners, midwives, physicians, family practice doctors, OBGYNs, has been posting information of this sort for a decade. He's now passed on the leadership of this listserv to someone else in Vancouver, but the numbers of studies that these practitioners come up with, quoting the safety and efficacy of this approach, make me wonder why we haven't done more so far. And obviously, it's sometimes about the money, it's about the perverse payment incentives. We don't get into that right now, but Carol Sakala has written a great deal about this, as you well know. We have other folks in academia who have written extensively, and we have got to change the paradigm so that even in a hospital setting, we can have what we would call truly low risk, less medicalized care for the women who are choosing the hospital setting. We don't have midwifery services in most hospitals in this country. I consider that insane, given what you've just said. We've got to change this, and it won't come easily, but if we all work together, we might get there someday. Wendy, do you have something you'd like to add about this? Oh, Nashira.
I just see a question from Norma Swenson that I want to honor and answer
Yes.
in the chat, which is around the state regulations requiring birth centers to have OB and medical director. That's true, and it's an example. I think it's something that we're working to kind of meet that regulation, and also concurrently wanting to work on policy to address those state regulations and make them more equitable for all of the reasons that Judy just said around low risk cases and the relationship. And also someone said in the chat how nurses have it's called independent license right now, independent practice. And so that the idea that we need a medical director on staff is actually really good in terms of our budget, right? And in many ways creates more inequity and makes the birth center kind of economic model less viable. And I think that we can establish relationships with area docs and really good relationships and good transfer protocols and really build relationship and trust such that area providers really refer to and trust the care at the birth centers. And what I've heard from other birth center leaders is that midwives are able to make the high risk calls. And so the idea that, so they're actually not doing a whole lot of high risk chart review. this idea that they're sitting down and asking a physician what to do with a case. Midwives know the answer to that and are making those decisions to transfer folks who risk out of the birth center. So yes, we need some policy change. That's one of a couple state regulation things in the Massachusetts state regulations that are actually creating barriers to us and future birth centers opening.
I see a comment that came a while ago from Marge Cohen. Hey, Marge, that I'd like to try to tackle. She asked about how a women-centered universal Medicare for all or a single payer system might help address some of these issues. And in terms of the assisted reproductive technologies, some of the problems that I was listing have to do with the profit motive. Some of the problems that I was listing have to do with the fact that people are trying to please the contracting parents, and that it's so expensive that the contracting parents want to, sort of shoehorn as much possibility into one round as they can, because they don't want to have to pay for it over and over. And in these circumstances, people are not usually, and in my experience, quite widely, even including highly educated people, aware of all the risks that are involved for every player in this, including, I want to emphasize again, the babies. So if there were something like a single payer system, a lot of this would go away. I mean, the issues wouldn't go away. And the point I'm making about disaggregating pregnancy and physiological processes into commodities would still be a concern, but some of the excesses would go away because we wouldn't be worried about making lots of money out of them.
Somebody just asked a question about my own home birth, almost 39 years ago. And it really is, for me, a very different climate we live in right now. I think that there is heightened concern about risk. I think many of the younger couples I've spoken with are very worried about what if, they're not as comfortable with the idea of home birth. That said, because of COVID and because of growing awareness of the literature, and by the way, to someone who asked about the literature in terms of other countries and outcomes, yes, there is literature, and we can put that in the resources later, where we get better outcomes, and it looks like it's because of the greater use of midwives. You can't prove that, but it's looking that way. We haven't been able to do a randomized control study, where you send this woman who seems in the same risk category to a home birth, and this woman to a birth center, and this woman to the hospital. Nobody's going to allow their births to be treated that way, of course. So we're never going to have the sort of gold standard proof that some people might like. But we are amassing a lot of evidence pointing to all the things Nashira has said, and that we just need to create the community settings where this will be possible. When I had my daughter many years ago, I didn't face any of the frowns, the approbation. My OBGYN, it was then Harvard Community Health Plan, was trained in South Africa. I was not the first woman. He said, fine, go have your home birth. He knew about a lot of home births back in South Africa. He said, if you need me, I'm here. And, we'll get you to the hospital. I think there's a lot more concern, maybe it's liability, who knows, but there's a lot more negativity towards out-of-hospital birth, not just home birth, but even birth center births amongst many medical professionals. It's probably the result of their training. That said, I also want to say that our birth center regulations do not require that an OBGYN be on staff. We have to have a medical director, but that person does not have to be even present in the facility. These are midwifery-led birth centers, and that's a good thing. And the former governor, Paul Salucci, who was a then state rep when we developed these regulations for the birth center, is largely responsible for a very positive approach towards midwives and safety way back in the 70s and 80s when we were looking at this issue. Don't forget that nurse midwifery in Massachusetts wasn't legalized till 1977. That's pretty recent. Okay. The other thing I would like you to talk a little bit about, Wendy, is the growing interest in what we might call designer babies and the use of genetic technologies and coupling that with IVF and the way in which some of your students are thinking about this.
And many of my students have also been involved in selling their eggs and now are under a lot of pressure from many sources to freeze their eggs. You know, it's coming down on them hot and heavy. The designer baby question is really, really a tough one. People want their child to have, you know, the best shot at everything. But it then what has happened is in certain places, not certain places, among certain people, it's elided into an interest in choosing the characteristics of your child. And those range from really deep, profound characteristics, as if one could choose intelligence, but that's the effort, to trivial characteristics like hair, you know, and there are many companies out there who will tell you that they can provide screening technologies that will then enable you to select which embryo you want to implant. In other words, you're looking for characteristic X, Y, and Z, and they say we can figure out if this embryo has those characteristics, and you can decide you've got 3 viable embryos. You can choose the one you want or the 2 you want, because again, remember in this country, they're implanting 2, whereas in Europe, for much more concerned for safety and health, only 1. So I think that's something for us all to really talk about a great deal. And we know that the disability rights movement has raised many issues in this domain around things that people were trying to screen and choose away from. But it goes way beyond at this point things that are considered disabilities to things that are just characteristics, as I said, like hair or eyes or height or whatever. One is that the technologies are really not very predictive right now. So they're making claims that they can't live up to, except in certain very crude ways. But the other is, I think we all have to think about this and talk about it. What does it mean if we want to look at babies as commodities? What does it mean if we want to look at our children and say we want this child? Does that mean we don't want that child? I mean, I think these are very profound political and philosophical issues. Did I come close to speaking to what you wanted? You wanted me to talk about CRISPR and gene modification.
Well, we may not have time today, and I think those are rather complicated issues at times, the phenomenon of 3-parent IVF. Mm-hmm. I am going to encourage all of the participants to go to the website of the Center for Genetics and Society, which is writing blogs and materials that are really essential to better understanding the complexity of these issues. I also think it's really important to understand that all gay parents don't think alike about these issues. I've talked to many lesbian mothers who do not agree with that bill at all that got through the governor's budget in New York State. There are differences in assessment of these risks you're asking other people to take. The fault, I believe, lies with the IVF industry, and I call it an industry because I think there are so many examples of failing to put the welfare of all the patients, not just the women who are the egg donors or the gestational mothers. And that's a space in which we have been very active at Our Bodies Ourselves. We created a website called surrogacy360.org, which was trying to point the floodlight on the problems that gestational mothers face in other countries. Their health and human rights are sacrificed all the time, and that needs to stop. And that website is now run by the Center for Genetics and Society. For example, and we were able to have a little bit of an impact in India. By contract, the gestational mothers were required to undergo cesarean section. Now, this is not a good idea. Elective cesarean sections, we all know, are fraught with problems. They're almost always not a good idea. And in this case, no woman should be forced to undergo a cesarean simply because she had agreed to be a gestational mother. Also restriction on a pregnant woman's movements in ways that were really not acceptable. Those kinds of things have been addressed by a number of global organizations concerned about how we are colonizing the bodies of women in the global south this way without attention to their needs and concerns. And you can always say, but what about all the money they're making? Well, first of all, it's not necessarily a lot of money, but second of all, we have to think about how financial incentives sometimes become very close to coercion when you are living in a state of dire poverty. We saw this with the whole scandal around the sterilization of men in India. They were getting sterilized, sometimes seeking sterilizations twice because there were payments and people were very poor. That was a campaign that actually led to a very negative view of the Ford Foundation for many years in India. So we have to remember that the way in which we carry forward what might be a good idea, or at least we have good intentions, might not be what ends up happening. So we have about 7 minutes left. Is there anything either of you would like to say? I can see we haven't been joined by Charlie, and what I will promise to do for the participants is collect her slides, make them available with the other slides when we post the link to this session, and also let you know that she is in a space occupied by other younger activists trying to bring menstrual collectors, menstrual cups to women across the globe. And she's focusing particularly on younger women and women in prisons because they do not have access to any means to control their menses in many cases. So the extreme interest in menstrual cups, I think, got going largely because of our concern about the environment, all these pads, all these tampons, it's not necessary, plus it costs money, and plus you can't resupply them all the time. So a menstrual cup that can be washed and reused is a great idea. And that's something that she was going to talk a little bit about, her work in Colombia and other countries, and her outreach to women, particularly in Latin America. So do either of you have some closing remarks you'd like to make?
I think just to sort of sing my same song, which is that I am very respectful of the many wonderful advances that biological-based science has brought us. Thank you for my COVID vaccination, amongst others. And at the same time, I think it really behooves us to be cautious and to really look for data and take a long-term view and assume that what we see in the first 5 minutes may not be the same thing that we see in the next 5 years. And I don't mean that we should be paralyzed. I got my vaccination now, even though there hasn't been a 5-year follow-up, because indeed the risks seem so clear-cut to me, and the data thus far so reassuring. But I think that that's my song, that I think we should be very respectful and happy that we live in an age when there are wonders of biological science available to us, medical science, and we should always keep our minds open, scrutinize it, and demand that it be careful and cautious.
Thank you, Wendy. And you, Nashira?
That's perfect, Wendy. I was going to say, I similarly am grateful for the advances in medicine. I saw someone sharing about their C-section and ultrasound, and want us to also hold the history of healthcare capitalism and the industrialization of healthcare in this country. When we question, out of hospital, someone said to me, "Oh, you had, non-traditional childbirth," and I said, "Actually, I had the most traditional childbirth. It's just a history that it has been taken from us and that we don't talk about." And so, I would just say that it's high time that Boston's reputation as a healthcare rich city and Massachusetts as a rich state can only last so long unless we offer this as an option, that everyone in Massachusetts should have the choice and the option based on their health and their risk to have hospital, birth center birth, or home birth, should they choose. And so what we're trying to do is really just put the option on the map for folks who are low risk in their pregnancy. And I honestly believe that it has the potential to improve health across our population, and it really matters. And so I think there's a really big consequence if we don't advance this and get this right. And I hope that Neighborhood Birth Center isn't the only birth center, community birth center in Eastern Massachusetts. We've got to propagate and open more birth centers here. So yeah, thanks for the time and energy. It's been a long road, right, Judy? Like, you've been at this for many years, and so I'm holding the baton right now, and I'm looking for a partnership. And I think it's also just important, like, we don't have all of the answers, because what we're also trying to do is not replicate other birth centers because of the debt and the not accepting Medicaid and not being able to negotiate with payers, and so, and our commitment to co-locating with other healers. And so we're really trying to do something different, and in doing something different, we're taking a risk, and in that, I think, is great reward. But I know that we're doing something right when we're realizing that it hasn't been done before, and we're reimagining the future collectively.
Yes, thank you so much. And I do think that we are going to have success here. We're going to work at it. I also want to thank both of you for joining us, for thinking about these two issues in more depth. There's so much more to say. I wanted to talk about Ruth Lubick and she's a MacArthur Genius Awardee, for those of you who don't know, who started this amazing birth center and family center in one of the poorest sections of Washington, D.C., and it has flourished. And in the resources that we're going to provide later, I will share some of the articles and stories about that work, because it has been an inspiration for us here too in Boston. So although we didn't answer everything, and there was a good question about mental health crises and difficulties, especially during COVID-19, things that we don't necessarily understand well, but all of our bodies have been impacted by COVID-19. Someone's even suggesting that perimenopause has been made worse. We've got a fabulous website out there now called womenlivingbetter.org, run by Nina Kozlov, that probably will be taking on that question about how COVID-19 has impacted our perimenopausal experience. And she's working with researchers across the country on very interesting questions there. So much more we could talk about, but I think because we have just a few minutes left, I'm going to turn it back to Dean Galea to say a goodbye to everyone. I want to say thank you to both of you on behalf of all of the founders and the board members at Our Bodies Ourselves. Go to our website to learn more about what we're up to, even in our current state. Learn about all the foreign language translation adaptations we mentioned earlier, and stay in touch with us. Thank you.
Well, thank you. First of all, we got a note from Charlie Ruth Castro, and she had a family emergency, which is why she could not join us. She sent her regrets to everybody. And I think, Judy, your idea of asking her if we can post her slides is a really good one. So thank you for doing that. Secondly, one of the enormous privileges of what I do every day is the opportunity to convene groups like this, is to convene groups of people whose work I admire so much, and to listen to you and learn from you, and actually to listen and learn from the audience questions. I just thought the audience questions were terrific, and the back and forth that they inspired were terrific. And I want to thank the speakers also for going back and forth with resources. Nashira, as you're putting papers, I've actually been downloading what you've been putting on, so I can actually read them later. So I really, I mean, what a joy it is to be able to sit, listen, and learn, and to absorb and reflect on later. And I want to thank you all for making that possible. In particular, I want to thank Judy. This is the genesis of this comes from Judy. She really engineered this and thought about this. And I thought it was just a wonderful way to honor the school's long relationship with our bodies ourselves, as embodied in many of our faculty and the staff over the years. And I want to thank you for, perhaps more importantly, for everything you've done for the world, everything you do for the world. So really, thank you on behalf of all of us. Thank you. Thank you to the panelists, and thank you to the audience for joining us today. Everybody stay well. Have a good evening.
Thank you.